Today we have with us Dr. Stephen Sherman, newly elected chairman of the International Thyroid Oncology Group. Dr. Sherman, you just completed the annual meeting of ITOG. Can you tell us a little bit about what's new in treatment of thyroid cancer?
Well, I think the content of this meeting really highlighted very exciting trends in the field. The first is that just looking back over the past few years, we've gone from trying to identify drugs that might have any activity against thyroid cancer and trying to identify drug companies that would express interest in research for thyroid cancer, to talking about drugs where 75 to 95% of the patients seem to get benefit, where tumors can be controlled for varying length of time. Obviously, a great deal of discussion at this meeting about the just approved first treatment for medullary thyroid cancer with Vandetanib.
So tell us a little bit, how is the approval of Vandetanib going to affect patients with medullary thyroid cancer?
Well, for individuals with progressing and symptomatic metastatic medullary cancer, there is now an officially approved, very highly researched drug therapy that appears to be effective in controlling the disease. The fact that it has gone through a traditional drug development process and approved by the Food and Drug Administration, I think provides a great deal of encouragement to the field that this is possible and can be achieved. It sets a benchmark for how to improve therapies for people in the future.
So what is Vandetanib?
Vandetanib is what we call an oral small molecule inhibitor. So it's a pill that patients take that attacks medullary thyroid cancer probably in a combination of two ways. One is perhaps by attacking the mutated protein or proteins that appears to be responsible for creating much of medullary thyroid cancer in patients, both inherited or sporadic, but also probably by attacking blood vessels that are necessary for tumors to be able to grow and spread. I think one of the highlights at this meeting was an extensive discussion about the fact that right now, although we have a drug that seems to be effective in helping, we don't really have a very solid idea of how it is that it's working in medullary thyroid cancer. And therefore, not only to understand the biology of the disease and the drug, but how to make it better, how to improve therapy going forward. These are very critical questions to understand.
So how good is Vandetanib?
If you look by a measure of how long it took for patients treated with Vandetanib to develop further progression of their cancer, further growth, in a study that compared Vandetanib with a placebo or inactive pill, there was about a 1 year longer time for disease to progress if you took Vandetanib compared with taking placebo. At this point, there's not yet evidence that the patients treated with Vandetanib live longer, but the study's going to have to continue to observe what happens to patients treated for a much longer period of time to be able to see that.
So based on the studies that were done, which of our patients should consider this therapy?
Well, I think it's easier to say who shouldn't. The patient with medullary thyroid cancer who is newly diagnosed and hasn't had surgery or any treatment, this is not an initial therapy. For the patient who has surgery and still has, in blood tests only, evidence that cancer remains, which is a very common situation, that the calcitonin or CEA levels remain elevated.
What is CEA?
CEA, like calcitonin, these are proteins that are made by the tumor cells that we can measure in the blood, serve as a marker to let us know how much tumor basically is present. It's very common. Perhaps the majority of patients who have surgery for medullary thyroid cancer by these blood tests still have evidence that there's a little bit of cancer remaining despite what seems to be a complete surgery. This treatment is not for patients like that. The safety is not that great that it is justified for patients who may otherwise live long enough to die from something else. But for the patient who has metastatic or recurrent medullary cancer that we can see on x-rays, we can see on scans, and we can measure a rate at which it's growing over 6 or 12 months approximately, or who have these areas of metastatic medullary cancer and they're symptomatic from the disease. It's causing pain or it's causing severe diarrhea. These are patients where the studies would suggest that the balance of risk and benefit comes down in favor of using the drug.
So you've talked about risk. So what are the risks of using this drug?
Well, there are some risks that are typical of the whole category of drugs that attack blood vessels. And so symptoms like diarrhea and fatigue and high blood pressure are seen quite frequently, although usually mild enough that they can be managed. One concern that came up specifically with Vandetanib is a risk that there may be some changes in the electrocardiogram that in most patients probably will be asymptomatic and not cause any problem, but raise the risk in a small number of patients for developing an irregular and potentially dangerous heart rhythm abnormality. So that patients who go on to this therapy are going to need to be very carefully monitored by their endocrinologist or oncologist or whoever is providing the treatment to make sure that the drug does not cause the kind of EKG abnormality that could run that risk. There are other side effects as well, and one are the skin rashes, and particularly sensitivity to the sun. Patients treated with this drug can develop very significant sunburns. So a lot of education will be necessary about how to minimize the risk as well as to how to treat the rashes when they develop. Having said that, most patients treated with Vandetanib for medullary thyroid cancer were able to remain on the drug, and many for years of therapy, maintaining successful control of the disease and tolerating the side effects. The last comment would be that in many patients, lowering the dose can achieve a good compromise of controlling the disease with tolerable side effect.
So if I'm a patient with metastatic medullary thyroid carcinoma or medullary thyroid carcinoma that has spread to the lungs, liver, or bone, how do I know if I should consider this therapy? What are the worrisome features that would make you as an endocrine physician want to consider the use of this new drug?
Well, I think a careful staging examination, or what I say to patients, is trying to figure out what's where. Starting out with a comprehensive set of the right imaging tests to know where the cancer has spread and where it isn't. Following certain areas and tests over time to look for rate of change. Very often patients may not have symptoms, but they may have growing tumor. But symptoms commonly could include diarrhea, and by that we might mean not that 1 or 2 episodes, after a bad meal, but something that happens on a daily basis, multiple times a day. Pain that can't be explained by other means is an important sign potentially of spread of tumor that could involve the bone. Many patients with lung involvement may not have symptoms, although a cough or coughing of blood obviously is something that could bring up concern. But diarrhea and bone pain are, for many patients with metastatic medullary cancer, the most important symptoms of the spread of disease.
So let's suppose a patient started on this drug. How would they know whether it's working?
Um, well, variety of ways. The most important, in fact, is measuring on scans to see if tumors are shrinking, and in many ways that is our ultimate goal, to shrink and then go away if possible. But it takes mostly a set of scans. Improvement in symptoms would be important. The blood tests may or may not be helpful, especially calcitonin, which many patients with medullary cancer are used to following, may not be a useful marker of response to the drug.
Good. Well, Dr. Sherman, we're going to have to bring this to an end, but I wanted to just hear one final comment. Are there other drugs that look like they are going to be effective in the pipeline?
I think that's one of the most exciting parts of the meeting that we just had and the field. I mean, there is a rapidly growing array of drugs, and not only ones that work the same way, but increasingly a variety of approaches to therapy, and at the same time, rapid growth in companies and scientists who are interested in treating this disease. So it's a very exciting time to be in the field.
Well, that's wonderful news, and I thank you for this interview.
You're welcome. Thank you.